We can't hear you.
Yeah. Can you hear me now?
Yes, perfect. Thank you.
Okay, sorry about that. All right, I'll start again. So Dr. Sellers will be visiting us today and tomorrow. We're very honored to have her here today. She's an assistant professor at the University of British Columbia in the Division of Cardiology and a translational research scientist at St. Paul's Centre for Heart-Lung Innovation. She completed her master's at the University of Northern BC in vascular physiology and her PhD in pharmacology and therapeutics at UBC, which also included time at the University of Western Australia. Yes, Western Australia, Sharon, and at Yale. And her postdoctoral fellowship was with cardiac imaging at UBC St. Paul's with Jonathan Leipzig and others. She's fortunate to be supported by CHR at various stages of her training and her career. She's currently a Michael Smith Health Research BC Scholar and has published more than 120 papers. She's a member of the Heart Valve Collaboratory and serves as on the educational board of Cardiovascular Pathology, Frontiers in Physiology, and the Journal of Heart Valve Society. Her research work is primarily focused on determining mechanisms of bioprosthetic heart valve degeneration, bench modeling of the transcatheter procedures, and the development of insights to new imaging techniques for cardiovascular disease using in vivo and ex vivo models. We look forward to Stephanie's talk on her translational science perspective related to valve disease. Stephanie.
Thanks so much, Dr. Beamans. Can everyone online hear me? I assume it's still fine. So I'm happy to be here today and really looking forward to giving you, a global overview of some of the work we've been doing in the Cardiovascular Translational Lab at St. Paul's for the last few years, and then looking forward to meeting many of you over the next couple of days, and we can discuss further some of the highlights that we go over today. Before I begin, here are my disclosures. Most notably, some of the work you see today has been sponsored by Medtronic and Edwards Lifesciences and Terrace and Excision Medical. So just to give you a brief overview, the Translational Research Lab, what we currently run at St. Paul's in Vancouver, really has a variety of different members, which I'm pleased to direct, anywhere from our basic science and imaging components to cardiac imaging and clinical cardiac surgery members. We have members of our research nursing team and biomed engineering, and bringing all those different groups of people together. We have 4 main areas that we conduct research in within this lab. Is that we mainly focus on fundamental and translational and preclinical science as it relates to bioprosthetic valves. We are a bench testing center of excellence for the Vitro labs who make valve testers and hydrodynamic performance testers. This allows us to evaluate new devices as they come to market for companies. We also run a pathology core lab where we evaluate degeneration and dysfunction of new devices, mostly transcatheter valves and clips, as they're in large or early clinical trials. And then we also run a global explanted valve registry that allows us to collect failed and degenerated valves from around the world and really gives us a large repository of these valves to base many of the studies that you're going to see today on. And so really that allows us to come at different aspects of how we use bioprosthetic valves, and specifically looking mostly at transcatheter valves and transcatheter procedures. So in saying that, I thought today I'd briefly go over with you some of the ways we've been looking at transcatheter valve degeneration and some of the ways we've been using that insight to validate new imaging approaches, and then discuss some of the TAVR bench testing that we've been doing and the recent insights this has provided us to new procedures and intervention. And then just highlight to you ways in which we're using biobanking of explanted valves to really inform how degeneration and pathology of these valves really has implications for our reintervention. So our lab doesn't do a lot of native valve work, but I know a lot of people here may do some, and this is a very complex biology that I think a lot of people are still working out the very mechanisms of. And really, when we look at this, we do know that we still haven't found the exact right compound to really intervene or slow or prevent this complex disease, targeting many different areas that you can see highlighted here. And really, from a center that's really focused on valve replacement and valve repair, we really wanted to focus in on the fact that there's been a revolution of the use of bioprosthetic valves in the last 20 years. Obviously, for the last 60 or so, we've been doing surgical aortic valve replacement using both mechanical and bioprosthetic valves. But really, since Alain Corbier, who obviously we pay tribute to, passed away last week, did the first transcatheter valve in 2002, we've really had this new innovation and revolution in minimally invasive approaches to implanting transcatheter valves, whether it be in a various variety of transcatheter valves, from self-expanding to balloon expandable, tall frame or short frame valves. And we'll look at some of that recently. And we really chose to focus on this in Vancouver because from John Webb's first retrograde transfemoral implant in 2006, which he published, we've really had a long history of innovating in this space and had a unique repository to start to build a program and look at what can we actually find on the bench as basic scientists that help inform what's going on in the innovation that's happening in the clinic. And where we really wanted to start was from our large repository of failed transcatheter valves. And really the reality we're currently faced with is that all bioprosthetic valves will fail. And you see a variety of different valves up here, some of which you may have seen before, some of which you haven't. On the very top left here is one of the very first transcatheter valves that Dr. John Webb did at St. Paul's that came out many years later that we can see overt calcification in. And then we see different patterns of restriction and degeneration in this tricuspid valve and valve. We see some of the early first iterations of the Edwards SM3 device and the way that these explants allowed us to really identify some of the leak and issues and enable redesign of this. We see some of the early transcatheter mitral valves, this is the Tierra valve, and some of our really failed self-expanding calcified evolute valves as well. And what we see when we look at this is really there's a large spectrum of degeneration. There's a large spectrum of dysfunction that's going on here. And we really at that point have little insight to what's going on in these valves. So one of the first things we really wanted to do was establish the baseline. There's been a large body of literature that tells us how surgical bioprosthetic valves degenerate, but there hadn't, at the point of us doing this study, been any literature really at all on how transcatheter valves degenerate. And so we wanted to run through this list of things that we know make these leaflets thick and stenotic and really look at, are these things, do these run true in transcatheter valves as well? And so the study we set out to do remains the largest reported explanted analysis of long and short-term transcatheter valves that allowed us to look at leaflet thickening over time. And what we found in this study is that, in fact, as we anticipated, that leaflet thickening increases with implant duration. These leaflets in a standard transcatheter valve, which this is an example of an Edwards sapien valve, which is usually about 400 microns wide, will triple or quadruple their thickness and have different aspects of pathology in them. And so we wanted to start to break that down and start to learn what is actually going on in these valves. We chose to look at three main components and understand thrombus formation on these valves. Obviously, halt and hypoattenuation on these valves is a large concern. And then we want to look at how these valves fibrose over time and then start to put a timeline on how these events start to occur and how they interrelate. And what we found when we laid this all out was actually quite interesting, is that at a microscopic level on explant, we see thrombus on all of these valves, no matter how long they've been implanted, anywhere from a couple hours up until 2 months. However, when we see a valve, a transcatheter valve that's been explanted after more than 2 months, we always find fibrosis in these valves as well. And it's always in combination with thrombus formation. And then at 4 years, we also see calcification start to occur in all of these valves at a histological level. The caveat of that being in the setting of infective endocarditis, in which histologically you'll always find microcalcification and calcification of those leaflets at that point. But what that sets up for us is a pathway that tells us that initial thrombus formation is always found on these valves. Within a very short period of time, within 60 days, we start to see fibrosis and remodeling of those valves. And within 4 years, calcification has set in at the histological level, giving us an actually much shorter histological timeline than what we see clinically right now, and expecting these valves to last 8 to 10 years. This timeline on a bench level has then been repeated in smaller cohorts by other groups as well. So we really wanted to delve down into some of those topics and histopathologies that really stand out to us. One of the questions that we're always asked is, when you see thrombus on these valves, does it look like what we expect to see on CT? Obviously, we see HALT as a meniscoid accumulation at the base of the valve most commonly. And in fact, on histology, you can find this pattern in at least 50% of the valves we take out, where most of the thrombus formation is at the base of that valve and is mostly located on the aortic side. But it would be important to note that you can also find this on the ventricular side, and it doesn't necessarily need to take this pattern. And we see hallmarks in that thrombus that tell us it's forming under both laminar flow and turbulent flow. However, there are also questions that's asked is, does this correlate to implant duration? And in our case, if we trace this out on all the samples that we've looked at, it doesn't necessarily correlate to implant duration. It can be quite up and down relative to the length of time that valve has been implanted in. We were able to leverage what we'd looked at on thrombus in these valves and look at it in collaboration with Mark Dweck's group at the University of Edinburgh, and use these samples to validate his assessment of a new tracer called 18F-GP1. This tracer binds to activated platelets, and something in their patient cohort that they were able to show has very little avidity in native valves, but at baseline had some degree of avidity in all bioprosthetic valves, and that increased significantly in the setting of HALT. And the baseline level decreased slowly over time after implant. The question was, is this binding appropriately? Does this match what we're getting on the histological level? So using the same samples that we're able to leverage from our biobank, we were able to validate this for them as well. So what you're seeing here is a classic autoradiography presentation where we look at histological IHC marker that tells us that CD41, which is one of the heterodimer that this PET tracer would bind to, is very avid on this sample, and then we can bind that radiotracer and inhibit it as well, telling us that this is binding to activated platelets that we find on the surface of these explanted valves. But at the converse, we need to use these samples on the bench to say, what is it not binding to? And the key factor here would be, as we have early fibrosis on many of these valves, is it not binding to fibrosis? And what you can see in the second panel here is that, in fact, this is actually not binding to fibrosis. And in the same region, when we look at areas of calcification on these valves, this tracer is also not avid in those areas. And so what that really tells us is that we've been able to use these samples to really evaluate a new tracer, and that 18F-GP1 is a good tracer both on the bench and in patients for looking at thrombus formation and understanding more of the natural history of leaflet thrombosis and tracking this in patients to understand more of the biology that's going on and how that may relate to valve degeneration. Because what we know on the bench when we look at this, on the left there is a video taken in one of our hydrodynamic testers of an aortic valve in which you see two of the leaflets completely immobile due to thrombus. You can see the photo of that next to it, and then you can see the mapping of the thickness of that leaflet on micro CT as well. And we know across that leaflet, what we're seeing based on the mobility is different stages of thrombus, from acute thrombus through organized thrombus, and how that's restricting the valve. But really, that tells us that thrombus lumped together as HALT in general isn't necessarily telling us the whole story of what's going on with these valves. And we do know that mechanistically, a lot of us think that thrombus may be related to contributing to or accelerating structural valve degeneration. And we can find nice diagrams like this that propose mechanisms how which thrombus on a bioprosthetic valve may degenerate. a leaflet and cause that. I would just point out that we actually don't know if this occurs in transcatheter valves yet. And this is going to require a very distinct set of studies. And this is one of the directions that I'd be interested to talk to people here about. Something we're pursuing on the bench is different bench models to look at if this is actually occurring, and then using something like 18F-GP1 that we just talked about to look at this in patients and understand that. So obviously thrombus is a big topic. The other thing I commonly get asked about, because it's what we see when these valves are explanted, is the most obvious thing on CT is when these valves start to calcify. And the question is, what is this calcium? Where is it? How did it get there? How do we inhibit it? You know, a lot of companies, when they make bioprosthetic valves, claim that they're anti-calcific. At 4 years, we always see histological calcium on these valves. Using different approaches, we've been able to show that this is calcium phosphate that accumulates in these valves. I would also say it accumulates both in it and on it. So on the left here, you can see a nice nodule of calcium that's been stained black with von Casa, completely embedded within the leaflet. This is a confocal approach to show you that calcium is actually pushing apart and delaminating layers of that valve, which has implications for how platelets and inflammatory cells can migrate in, and something we can look at in assays. But what you can also see is that you actually get calcification of the fibrosis and other inflammatory cells that are on the leaflet and not necessarily integrated into the matrix of the leaflet. So as that valve thickens, you have more and more real estate to calcify and stiffen that valve. And so we also wanted to be able to leverage long-term explants of TAVR are fairly rare, and obviously we're getting more and more. But also as we move into TAV and TAV procedures, explant is less common. So we really have to ask ourselves, with these explants, can we really leverage them on the bench to understand more about how we image and understand calcification of these valves? And so similar to what we talked about with 18F-GP1 and thrombus, we're able to use these to validate PET tracers to understand some of what's going on in that real time about how these valves are calcifying, and if we can start to predict calcification of these valves. And so this was a study done by David Newby and Mark Dweck's group in the University of Edinburgh, who recruited 2 cohorts, both with and without known valve dysfunction, who underwent 18F sodium fluoride imaging and echo follow-up at 2 years. And what they were able to show is that the avidity of sodium fluoride in SAVR valves, surgical bioprosthetic valves, correlated to the stage of degeneration of these valves. And perhaps more interestingly, they were able to show that that avidity predicted the change in degeneration over a 2-year period. And so if we saw avidity of that tracer and no obvious calcification on CT, within 2 years, you could see calcification of that valve, showing that this was predictive of areas of calcification on this valve. That didn't really tell us in great detail what that tracer was helping us pick up. So we're able to leverage explants to look at that. And so what you see across the top there is 4 specimens of varying degrees of calcification and degeneration. And it's quite probably predictable that when we see areas of calcification, such as the nodules you see here and all the black staining across this one, that you would expect these to be sodium fluoride avid. They're binding to the calcification. So that really made a lot of sense to us. But in a number of valves, you'd see this is a very thick leaflet that is highly dysfunctional in a stenotic valve that has no discernible calcium on micro-CT or on histology. And what we were able to determine is that sodium fluoride was also able to predict levels of microcalc that we can only see using like a scanning electron approach that's below calcification. And it was also binding to different enzymes that are within the leaflet, such as matrix metalloproteinases, which would eat away and degenerate and thicken that leaflet over time. Really telling us that this was a tracer not only allowing us to look at calcium, but other processes that break down and stiffen that leaflet. The second part of this trial that was published 2 years ago looked at TAVR valves in this cohort and found a similar finding as well, that this tracer was really useful for evaluating the extent of degeneration and predicting annualized change and dysfunction of this valve as well. and that we saw similar things when we looked at this on the bench, that we could actually validate that this was binding to areas of degeneration, most specifically to areas of calcification, but also similar to the Sabra valves, areas in which we had thickening and breakdown without overt calcification. What was interesting about this study is that obviously when this was being done in patients, we kept seeing a lot of avidity in the native valve. And that would make sense because we would do TAVR in the setting of severe aortic stenosis. There should be a lot of calcium in the native valve that is displaced. But as the study was going on and the group in Edinburgh kept sharing their clinical scans, they kept saying there's more and more avidity over time in these native valves. And what is going on here? Like, and you know, originally the fellows working on this were like, it's okay, we can gate this out. It will just make sure that none of that's included in our assessment of the actual bioprosthetic valve. And we had to kind of take a step back and say, is this telling us something interesting? Long term, most of the narrative we've been giving about aortic stenosis and native valve disease is that this is disease and wear and tear. The valve is opening and closing, and that mechanical insult has driven that aortic stenosis and degeneration over time. But this valve is immobile. It's basically, you know, crushed against the side of that transcatheter valve that's been placed in it. And so this was kind of telling me perhaps we should go back and look at this. And so, well, transcatheter valves that explant are relatively rare. Having intact aortic roots on long-term transcatheter valve explants is even more rare. And we were able to get a cohort of about 25 of these, in which we had completely intact native valve specimens. And that looks like this. And we can, you know, explant the transcatheter valve and take apart the root and cut each of the individual native valves and look at what's going on in this. And this was actually the study that for the first time using a number of markers. Here you see RUNX2 and osteopontin markers of ongoing native valve disease that showed that, in fact, these markers were still active, something we see up to 8, 9, 10 years post-TAVR, telling us that even if we've immobilized that valve, the mechanical wear and tear on that valve is not required to continue this disease process. And on imaging, that correlated to sodium fluoride continuing to go up post-implant, really telling us that calcification of both the native valve and the transcatheter valve are going to be an issue for us and something we're going to need to understand. Obviously, if these calcific nodules are continuing to grow and remodel post-TAVR, and then we want to plan a second intervention, there's implications for how bulky that calcium has become and how rigid that native valve has become to try and put a second valve in. So something we've also been asked is, how does calcium differ across platforms? Obviously, the two major platforms that we talk about are the interannular balloon expandable SAPIEN device made by Edwards and the self-expanding tall frame valve from Medtronic, either an Evolut R or an Evolut Pro. Usually, but how does this differ? Do the designs and hemodynamics of this actually tell us that there's going to be different calcification? And does that calcification have implications for putting in a second valve, explanting that valve? And really, at this point, up until last year, there hadn't been any detailed analysis of that. This all reports on degeneration in transcatheter valves had not subdivided by different device type. And so this was something we'd wanted to look at and do in detail and had the opportunity to do. And we did this using a micro CT approach of explants that we had available to us in our global explant registry that were intact and not crushed, and were able to be imaged by micro CT. And we were able to then break down the calcium based on its location relative to the free edge of the valve, the base and the middle, something, or the sides or the center, something that has implications for some leaflet modification that we'll talk about briefly in a minute. So here are the samples that we looked at, all having various degrees of reasons for explant, the majority being explanted for structural valve degeneration, some for non-structural valve degeneration, a small number being explanted for endocarditis, and then some having a mix. The median time to explant was 3 months and 3 years and 3 months, which seems short, but for a TAVR study is actually quite long, and there were a number of long-term explants, and we've continued to add to this over time. Hopefully you'll see this publication soon come out. And we're able to map the calcium in detail to understand where this calcium is most likely to occur and how this relates to the gradient and stenosis of these valves. And what, in fact, we were able to find is that if we break this down, we actually see some starting to emerge differences between the two platforms, between Evolute and Sapien, so tall frame, self-expanding versus interannular short frame valves. And we see that in the core valve or Evolute, it appears to be more evenly distributed proliferally with 60% or so on the sides of the leaflet, opposed to the Sapien appears to be more towards the middle with about 60% at the center of the leaflet. What else interesting is that most people I speak to generally associate most of the pathology they think about on these bioprosthetic valves as being on the aortic side of the valve. But that's, not what we see in this study. It's not what we see histologically as well. And that there's both calcium on both the inflow and outflow aspect of these valves. And also that calcium is both extruding from the surface, while it's covered by a layer of endothelium and is encapsulated. It's both on the surface of the valve, but it's also worked its way into the actual leaflet itself and stiffened that leaflet from the inside. So really this detailed micro CT has really validated what we saw histologically in the first study I shared with you. And what we can do in the lab now is put all these valves back in a hydrodynamic tester. So this is a left heart pulse duplicator that we use. And hopefully this valve is moving for you on the screen. But really start to understand how the calcium and how the pathologies relate to how that valve is actually opening and closing. And one of the key things that we found so far in doing that is that really the hydrodynamic function of that valve doesn't necessarily correlate to the calcium load on that valve. We see a poor correlation to that. However, the hydrodynamic tester, when we put these exponents in it, really does reproduce what we see on the bench, and we see similar gradients generated in our tester that we did prior to expont of this valve. So really by mapping this calcium, we've really for the first time gotten a really deep understanding of how these valves calcify and how the leaflets thicken and degenerate that may be non-calcific as well. And understand that in fact, high gradients are not necessarily being driven by leaflet calcification, but in general being driven by leaflet thickening. And that calcium distribution may differ by platform. We see more peripheral calcification in the Evolute platform, more centrally located calcification in the self-expanding Sapien cohort. And that, we want to look at now and what the implications for this distribution are. And that really brings us to some of the other stuff we do in the lab is really look at the complementary role of bench testing to understanding pathology. In general, bench testing of transcatheter valves allows us to evaluate THV platforms, non-nominal conditions, look at new procedural techniques, and build training skills labs for fellows and trainees to practice different procedures on the bench. And then it allows us a better understanding of device durability and how pathology is implicated in that. So the two main tools we use to do a bench study like this are a hydrodynamic tester. We commonly use the Vivitro tester you see on the left, which allows both testing of aortic and mitral devices of various sizes, all the way up to some of our large new mitral transcatheter valves, and then accelerated wear testers as well. And so that can allow us to do simple things that don't involve pathology at all. This is just a snapshot, for example, of the first bench evaluation of the new Duravar valve. It's the first-in-class biomimetic molded leaflet transcatheter valve from Antares Technologies that allowed us to look at this and present this for the first time to really understand how that valve is opening different. This was done in combination with their early feasibility study, really lending bench evidence to what they're seeing clinically as well. But as I mentioned, we can also do non-nominal conditions and look at how things like a non-elliptical deployment under expansion may impact gradient, effective orifice area, opening and closing times, opening and closing pressures. All kinds of different metrics can be derived from these two testers. And we spent a lot of time doing bench testing on pristine valves. And I'm happy to chat with everybody about, what we found using that. And we wanted to stress that those bench tests are done to ISO standards, and that running a bench testing valve program like that takes a lot of regulation and organization, and is often used in FDA filings for these new companies or evolving indications for well-established companies. And so that is a large component of what we do. But I thought what might be more interesting to look at today is how we've used bench testing to look at how pathology and valve failure is actually implicated in bench testing, and really a hybrid of what we've been doing from the very pathological basic science point of view and what we've been doing from the bench testing point of view. I thought we'd take a brief look at 3 different areas. What we've looked at in terms of valve fracture, leaflet modification, and then one of the studies we've done on TAV and TAV procedures. So valve fracture using a high pressure balloon can be used to achieve, fracture of a degenerated surgical valve in which the frame of that surgical valve is fractured to increase the area for a second transcatheter implant. And so one of the studies we looked at was the implant of an accurate neo valve or Sapien 3 device into a mitral flow valve, in which we fractured these valves. So on the left-hand panels that you can see, those valves are quite restricted on photography fluoro or micro CT, but post-fracture using a high pressure true balloon, really we get much better expansion. And then when we use that in terms of the hydrodynamic tester, you can see in both the Sapien and Accurate platforms that we get improved gradients and improved EOAs. And then we can also, from the high-speed videos, look at things like what is the redundancy of the leaflet tissue. So as you have a more expanded valve, you can see on the right here, that you have a lot less tissue redundancy. That leaflet is not pinwheeling on itself. There's not as much mechanical strain and damage occurring to that valve. And so this is the classic pristine bench test. And then the question was, how can we take what we've learned from pathology and really expand on that and really, take the next step in bench testing of transcatheter valves? And so what we decided to do was take some of the tools that we've really leveraged to look at pathology and apply them to this bench test. And so this is the setup that we just described. So an accurate neo or Sapien 3 implanted in mitral flow. We did 2 different sizes of these and then fractured both before and after THV implant, and then looked at hydrodynamic function of these valves at baseline, and then ran these valves for 200 million cycles, and then looked at hydrodynamic performance again. And from the initial bench test, we were actually able to show that valve-in-valve fracture performed after actually is associated with better EOAs and without a reduction in regurgitant fraction. So there's no trade-off in terms of regurgitant fraction, but you're getting a better EOA if you're doing that fracture post-THV implant. And where the pathology part comes in then is typically this is where the bench test would end. And we would publish this as a bench test using pristine new valves. But we really wanted to make sure we looked at this. And so this was the first report in which we leveraged some of the confocal and histology approaches that we've been using to look at this. Because the argument for fracturing a valve prior to implant is that you may not damage the transcatheter valve. But by getting that better hemodynamics, what happens? So what we were able to show is that if you fracture before, you actually do get more micro damage. And we can see this on confocal and scanning electron microscopy to the surface of the valve. But once you get about 30 microns into that valve, you actually have preserved that valve by fracturing after. And if we look after 200 million cycles, that valve is very degenerated if we fractured beforehand, because the valve is so underexpanded and that extra tissue is continuing to pinwheel on itself and have much more damage to this valve. And so really, that was one of the ways that we were able to leverage those tools from what we've been using to look at pathology of the valves to really advance a bench study to inform a decision on fracturing before or after in valve. But we really wanted to look directly at the pathology as well. And the question we wanted to start to answer, and something we've been continuing to look at, but this is a brief snapshot of something we published last year, was looking at what is actually the implications of that degeneration. Does it matter how that valve degenerated and you choose to fracture in terms of embolic debris? So this is two examples. On the top, we see a highly calcified valve. So what we do in here is take the fresh explant immediately from the OR and fracture it in a fracture chamber, and they are able to capture all the embolic debris. And what we see is that we're getting flecks of calcium, we're getting flecks of fibrosis, we get flecks of thrombus, but we're also getting pieces of the valve, small pieces of the valve coming off as well. Opposed to on the bottom here, where we see a valve that is much more fibrosed, less calcified, and the calcium that is in that valve is very encapsulated within that fibrosis. When we fracture that valve with a high pressure balloon, we get very little embolic debris. And so really this has yielded the question of, should we be characterizing the nature of degeneration and pathology of these valves before we choose to fracture, or before we choose to use or not use embolic protection when we're doing this? So this is something we continue to do with all fresh explants that we can get in the lab and start to understand and map that, and really then try and link that back to the CT features, but it's something that is a ongoing study in the lab. So the other thing we want to talk about in terms of valve fracture was also leaflet modification. So in general, leaflet modification refers to altering the bioprosthetic or native leaflet in some manner, most commonly to allow coronary blood flow to be maintained. Here we can see an example of different ways in which coronary flow can be obstructed in a valve-in-valve procedure. And on the left here, you can see an example of electrosurgical cut to that leaflet that has split the leaflet and allowed areas for blood to flow through that would normally obstruct the coronaries. So in a very short amount of time, since essentially 2018, when Robert Lederman and Jaffer Khan and Toby Rogers first described basilica for electrosurgical alteration of these valves, there's been a lot of different devices and procedures and approaches to altering a leaflet to prevent coronary obstruction, either native TAV or valve-in-valve or TAV-in-TAV. And the question really hasn't been asked, what are the pathological implications for that? Are some of these different procedures more likely to work if a valve is calcified or fibrosed? And that's something we've really been drilling down on in the last year in the lab and trying to understand. And to do this, and I'll just give you a brief snapshot, and hopefully we'll have more to share in the next couple months in a publication that will come out. But we've really wanted to look at an electrosurgical approach on the left, in which a denuded wire through insulated catheters is electrified and essentially vaporizes that leaflet and creates a slit and splays that leaflet, opposed to a mechanical approach. In the center, we see the Cardiology device that just achieved FDA approval that mechanically cuts that valve using a hook, and then electrosurgical combination with mechanical as well on the right, something known, depending on how exactly you're doing it, as a unicorn or cleave procedure, in which an electrified guide wire traverses the leaflet, but then is replaced by a balloon to make a hole in that degenerated surgical valve. And then within that leaflet, a transcatheter valve is deployed. So we've been modeling these on the bench using explants to understand what is actually going on. Is there different pathologies that work better? Different procedures, that work better for different pathologies? And what are the implications of using those different ones? And I'll just give you maybe a striking example from one of the first studies we did. I think we'd all agree that this valve is highly calcified and really quite stenotic. And we wanted to ask what would happen if we were going to mechanically lacerate this using something like the Cardiology shortcut device, or in this case, we used a blade on a single axis jig. Or what would happen if we do this using electrosurgical laceration, and looked at this and found, what's going to happen here. And what we found interestingly is that the cut from the mechanical one is much more jagged, opposed to the electrosurgical laceration is much more straight, much cleaner. What we also found interesting is that, in fact, when we looked at embolic debris generation, the electrosurgical laceration had done exactly what it had wanted to do. It vaporized that tissue. It created a very clean cut. We didn't have any embolic debris. Getting a blade through this really generated a lot of embolic debris. And we wanted to look at this on histology as well. And so when we take these leaflets off and look at them, we can actually look at how that difference is and look at how clean the cut from the electrosurgical laceration is versus the very rigid and fragmented cut we get from a mechanical laceration. Understand that. So this is something we're continuing to work on and compare all these different mechanical and electrosurgical approaches to doing leaflet modification. Obviously, we'd like to do this on explants, but explants are limited. And once you've done this, you lose your ability to use those valves in bench testing. And so something we've also been working on is a number of different ways to make artificially calcified and degenerated valves on the bench. We do use that purely using a chemical approach, and we actually work on this using a cellular approach, using programming of valvular interstitial cells to calcify it and make an artificially calcified valve. And here's an example here of an artificially calcified model in which we managed to lacerate and use this as a model to understand leaflet modification. So leaflet modification is a big topic when we talk about valve and tab and tab. And the last thing I'll kind of show you is how we've leveraged our insights from pathology to understand transcatheter valve implantation in a failed index transcatheter valve. And really the example I'll highlight, that we've done this in a number of different ways, is looking at what happens when we have a failed tall frame self-expanding evolute valve. Originally, we did the pristine bench test on this, looking at putting a sapien valve inside a failed evolute valve. This is actually the recommendation from Medtronic, is to do this. Use another company's valve to replace their valve, which is interesting, but they didn't know what height to put this at and where this should be placed. And so the original bench test we looked at was looking at different heights of deployment, low at node 4, intermediate at node 5, or high at node 6, and looking at what that resulted in. How much leaflet overhang did you have? What was the hydrodynamic function? And that included that you really node 4, node 5 is where you want it to be. But the argument against this paper is that it was done in brand new evolute valves that aren't failed. And so really we had a unique opportunity to utilize failed degenerated evolute valves to look at this again and really leverage what we've been working on in terms of calcifying these valves and looking at these from the THV registry. And so we were able to use 4 calcified valves. We chose 1 of each size and then performed implant of sapien valves in these. And what you can see from the initial assessment is in the hydrodynamic tester is that these valves all have a significant amount of calcium on micro CT. In the hydrodynamic tester, you can see that there's varying degrees of a delay in opening, and you can see the stenosis that's occurring in the hydrodynamic tester. And all of these valves had a significant gradient at time of explant. So really the valves we chose to test were stenotic, good examples of failed degenerated evolute valves. And what we were able to do then is implant sapien valves in these and look at what was the hydrodynamic effect of this. And we found that in all cases that we were able to show that we had acceptable EOAs and mean gradients on implant of that new sapien in a failed evolute valve, similar to the pristine bench test. The one difference being that on the 34 millimeter evolute, we did have a above ISO accepted standard of regurgitation. We determined that to be through central leak through those additional studies, and really found that this stressed that planning and CT planning of this was important, because the degree of leaflet thickening on this actually means that we should have downsized the sapien valve, telling us that the pathology in this case was important, that the leaflets were so thick that that sapien was very restricted and that we had a lot of central leak going on in this valve. What we were able to also show that despite these valves being very fibrosed and the frames having a lot of ingrowth, that implant of that leaflet still was able to deform the frame, and that it was also had an impact on leaflet overhang. So in the pristine bench test, typically we see that the overhanging leaflet is very mobile. Opposed to in this bench test, the overhanging leaflet is very immobile. There's very little difference in the actual leaflet overhang over time, telling us that that stiffened leaflet may actually be an advantage to not having a leaflet causing a lot of turbulent flow flipping around, and that the stiffened leaflet was actually a much difference caused by pathology in this case. And what that also allowed us to show is that, in fact, the EOA generated using that valve is actually always in excess than what we expected it to be. And in fact, it's always that the GOA created by that leaflet overhang exceeds that, telling us that this bench test is really representative of what we did initially, but there are some differences created by that pathology. And finally, just looking at the frame deformation, showing that similar to when we did the other bench test, there was some slight differences caused by the stiffening and thickening of those leaflets, but we still get a certain degree of frame deformation in these valves. And that what was the key point of this study was actually looking at the ability to reaccess these coronaries. We were able to reaccess the coronaries modeled on the bench. That doesn't mean you can do it in patients, but what you can see is the amount of room you actually have to reaccess those coronaries and get a catheter through there is much smaller. But maybe one of the most important findings from this study is that when we used failed valves instead of pristine valves, what you can see in this video and in this photo as well is that calcium from that failed valve is actually extruding through the frame of the second valve that's been implanted. And every time that valve is opening and closing, it is hitting that calcium. So your brand new SAPIEN 3 leaflet that's supposed to last 8 to 10 years is hitting a piece of calcium every single time, and that calcium is quite sharp, and it's doing it in multiple areas throughout the valve, and something that is quite, problematic. And so when we talk about where this calcium maps to, maybe it's important to understand where that calcium is, or maybe we needed to modify those leaflets like we talked about before we do this implant. So doing different combinations of this and understanding this on the benches is where we're going there. But really, this bench test allowed us to show that really at this node forward deployment using pathological valves, really we still get that reduced neoskirt height. There's no significant compromise. The SAPIEN 3, the leaflet overhang is actually improved, and that is stable and doesn't vary throughout the cardiac cycle. But there is calcium extrusion, there is under expansion of that valve, and really we need to think about how we're going to inform planning of TAV and TAV procedures based on these findings and based on what we know of patterns of failures of index valves. So I think there's 10 minutes left for questions, so I'll wrap up, but I really wanted to hopefully just take you on a brief overview of what we've been doing the last couple of years and really show you that really THV durability and degeneration is a highly undercharacterized complex mechanical and biologic process that we're still looking at and is the main focus of what we look at. We leverage our knowledge and understanding and resources in that to look at how we can help validate new PET tracers for this, and really that's offering an emerging method to better understand degeneration. We use bench testing both in pristine valves to understand new valves, complex situations, and new techniques. But we also want to merge what we understand from pathology and our bench testing to really create better models and analyses that more accurately reproduce the clinical situation. I would be remiss without thanking everyone who's contributed to this. So obviously, we have collaborators all over the world that contribute to this and great industry partners, as well as the Transcatheter Heart team at St. Paul's, everyone who's been involved in the lab for this. And so with that, I'll take your questions.
Right. So if there's questions online, I'm not certain how I see those. Are they up there? Oh, there's some in the chat. Let's have a look. We get to the chat there.
Don't see it.
Yeah.
Do you have to exit?
In the chat. Yeah. And I'll be present on the part. Yeah. Thanks. Yeah.
Stephanie, Mark, well, this was a great talk. Just a couple of quick questions about HALT. First one is SAVR valves, same phenomenon exactly as you've seen with TAVR?
We have not looked at head-to-head SAVR versus TAVR is a question that we get asked from a HALT perspective and a degeneration perspective. And we've really stayed away from doing it because the questions really become, how do you match those cohorts even on the bench? It would be like, do you match based on patient characteristics or valve design? And so in general, it seems to be similar. What that is. But we have not looked at that directly, but certainly I think we have things like the frame of the valve. So nitinol versus cobalt chromium will activate platelets differently. That's something we hope to get at. We recently got an IHR01 for looking at platelet signatures in patients for TAVR and SAVR and looking at different bench models on the bench and looking at that.
So as you know, HALT is controversial. Like it seems that warfarin, oral anticoagulation, once it started, doesn't really do much in series. I mean, we've all seen it in individual patients where the gradients have come down, but when you look at larger data, like it doesn't seem to do anything. And in the same vein, no pun intended, the DAPT, has been found to be ineffective. That was only short term after TAVI. But do you think we're missing something there from a therapeutic point of view? Should we try to have more antiplatelet action? Should we try to orally anticoagulate these patients even before HALT happens? That was
Yeah.
a great talk. Thank you.
Yeah. I mean, I think I might have a slightly controversial view on this, is that I think we could, from what we see histologically, there's always platelet activation. We've done this by SAM, we've done it by IHC, we've done it on, ex vivo models. No matter what, if we explant, there is some degree of platelet activation, some degree of thrombus. And I don't think we'll achieve a great enough anticoagulation strategy to really get rid of that entirely. So then the question becomes, can you ever shut down that mechanism if it is driving structural valve degeneration? So should the approach then be to go back and redesign leaflet coatings, something we've been working on, or seed that valve or protect it until it endothelializes? Or is the approach to understand what is the step down the pathway from that thrombus if it's not causing an acute clinical problem that stops that degeneration? Obviously, if you have an acute clinical problem, you need to treat that. But in terms of degeneration, I think we should look down the pathway, because I don't think we're ever going to achieve anticoagulation to an extent that we shut down that molecular signaling.
Okay, so great talk. This is Emilio. I have a question more related to the material science. This is what I do, right?
Mhm.
So, Giovanni Ferrari in Colombia, he published last year or the year before this great study that he's trying to correlate the glycation of the cardiac valves, of these bioprosthetic valves, with the incidence of calcification. So do you see any correlation with your studies on that? Because he developed this, like impregnation methodology, so it's basically soaking the valves into this methyl glyoxal molecule. And it is actually very interesting findings. That is question number one. And question number two, I saw that your wonderful machine, that is an excellent, by the way, I really like it. Is there any version of that machine that you can measure the mechanical properties in situ? Because I'm wondering if, we can get, we're missing some information in terms of the mechanical properties of the valve. I wonder if, because you have 2 dimensions in there, I wonder if you can put a laser in the back and you can measure the deformation of each one of the layers.
Oh, yeah. So first one, yeah, that's a great study by Giovanni. Great credit to him, amazing work. We haven't looked at that specifically. I know that's something we will look at using, we've been doing some multi-omics approaches and we've been looking at that. Something we haven't quite looked at yet, but I do know his colleague Isaac George and stuff is looking at coatings and stuff like that. Absolutely, the image I show you just projects really well from the tester, but essentially there are cameras that sit on the side as well. There's also, we can thread a endoscope through there and videotape that. That setup can also be used in a particle image velocity setup, so using to look at flow. Absolutely. So that system can be adapted to all those things. You can also dismantle it and do what you're talking about and do like steady state flow. So we get leaflet flexion. I just didn't put that data in here, but we have looked at leaflet flexion and those curves and stuff on explanted valves and new designs and things like that. Yeah.
So we have Mark and then Katie and then David. So Mark is asking, has calcium supplementation been examined in those patients with heavily calcified explanted valves? And I would add to that vitamin D and the other diphosphonates and other treatments for osteoporosis, hormonal therapies, if any of those have been looked at.
No, we have not looked at that, but inevitably highly calcified valves are from patients with chronic renal dysfunction. Absolutely. Those valves will often be the ones you see explanted at 2 years that are just very calcified. But no one's done that. There is a calcium supplementation method for degenerating valves ex vivo, but not to my knowledge, that hasn't been done.
Katie, are you able to unmute?
Yeah, can you guys hear me?
Yes.
Okay, fantastic. Stephanie, that was a great talk. I learned a lot. So thank you for, clearly explaining and really showing the process that you take to examine these valves. And I think that's really a triumph. So congratulations. And I'm wondering, in all of these, I mean, I can't imagine the number of specimens you've looked at over the years, and particularly at the pathology level. Are you beginning to, compare all the cell types within those, calcified and fibrotic valves? I mean, we know, I think we discussed, briefly last night, like we're learning about cell types that we didn't even know existed, 5 years ago in terms of differentiation states and transdifferentiation. Have you begun sort of those analyses of these explants to say, what are the cells that are present that are causing the pathology? How do they compare to the original pathology, similarities, differences, getting at that prevention, new treatments, et cetera?
Yeah, we've begun that in a couple ways. One is to understand, I showed you the native valve remodeling, to look at how the valves in that continuing remodeling native valve are reacting to the transcatheter valve.
Yes.
And understanding how that's occurring. But we've also on the failed valve started to look at cell populations, both using, standard IHC approaches, but multi-omics approaches as well.
Right.
The caveat that being that you have to accumulate enough valves, and for initial pathological studies we've done, obviously getting a very clean cut is important. So we've had to decalcify those valves.
Yeah.
So that sort of interrupts. So we've just been rebuilding that repository to look at that, but have done initial runs on that using different approaches with collaborators. It's not something my lab particularly is strong at, but have very collaborators that's highly specialized in that, and we're grateful to work with them on that. So we're doing that in combination with their native valve stuff to really understand what are those cell populations. What probably is most interesting is that the cell signatures seem to vary significantly by implant location.
Interesting.
So if we're talking about an aortic transcatheter valve or mitral or tricuspid, the answer seems to be much different.
Okay.
I stuck to aortic today, but we've done work looking at that, and that will be something, as we move to just finding clip versus TMVR or a TTVR, that will be interesting.
Okay, we can chat more later.
Thank you, Stephanie. Fascinating presentation. I have a lot of questions. I will just focus on few. I was a little bit disappointed. You have shown that the correlation between calcium score and gradient for explanted valve is relatively weak. First question is why? And second question, do you have images for fibrosis? And third question is, what is your view on the valvosoft, the technique to use ultrasound to soften the calcification on the valve?
Yeah, so the poor correlation, I think, is related to, I think we don't quite understand yet. It doesn't matter where that calcium is based on the valve design. So for example, if you're looking at like a Evolut versus Sapien, if the calcium is in the leaflet or on the leaflet, is that actually causing more stenosis of that valve? And then I think the poor correlation also comes from that we've drastically underrepresented how fibrotic these valves are. Because if, other than the way I presented it today, that the calcium isn't necessarily correlated, there is calcium, but not a lot, you could flip that and say there's a lot of fibrosis. Those leaflets are very thick without calcium. Something that many of our surgeons tell us, that they come out and they're not calcified. And so really telling us that those valves are very fibrotic, and that's causing significant restriction and stenosis as well. So really that's, if you look at the thickness of those leaflets, it's the thickness and fibrosis of that leaflet. We have done something that's still being worked on. We've done new fibrosis tracers for activated fibroblasts PET on these valves. And then my grad student, her PhD is on fibrotic mechanisms of restriction of these valves, looking at different fibroblast types, so getting kind of at Katie's question, and different patterns of fibrosis, even small amounts of fibrosis that can drive a very significant gradient. Approaches for softening calcium, are you meaning like a kind of like a shockwave approach? Like
The Lancet.
Yeah. So we haven't looked at that on the bench. Certainly, I don't know if it would then drive inflammation, like doing a balloon valvuloplasty. We haven't looked at that at all, but something we could look at. We've looked at that on the bench in coronaries related to doing shockwave in them, and to look at that using fresh coronaries. I focused on valves, but we do coronary work and aneurysm work. But It's something we really do want to look into, but just haven't had the time.
Yes, fantastic translational work. You know, I think it really has a great science together with clinical implications. Maybe to follow up, kind of 3 quick questions. One is that, you know, you really actually demonstrate very nicely in terms of the ability to use these PET tracers, for example, you know, together with the imaging to characterize, you know, what's happening in the pathology. Are these then in the, you know, positioning well enough that we can actually use them as the intermediate endpoints for interventional studies, you know, in that we can then design, you know, strategies to actually either predict or, you know, sort of intervene depending on risk. Second quick question is that besides the electrosurgical, which is fascinating, can you use the laser or other type of energy deposition, you know, to actually address that question? The third one is actually the fascinating observation of the fact that the native valve continue to calcify. Right. And so now the thing is that there are some studies, you know, certainly mainly aortic stenosis, suggesting things like LP little a phospholipid, you know, some of these things actually drive this process. And so are there host characteristics, you know, that you think could be actually differentiating, you know, sort of the pace of planted valve? Yeah.
Okay, so the first one was
Can you use the imaging to
imaging? Yes,
yeah.
absolutely. I mean, I would obviously the clinical parts of the studies I give full credit to Dave Newby and Mark Doek's group on, and that is something that they explore, you know, in detail. And those patients are all having follow-up. They're all enrolled in various trials, and I think that's something, you know, we proposed in one of the grants we're doing with them is using those as surrogate markers. I think the issue may be access and cost of that, right? Certainly, you know, even Vancouver, we would never be able to do that. That study, we don't know, you know. So, you know, I think it would be an interesting, but I think, you know, it currently isn't, you know, it doesn't correlate to any BARC criteria or anything like that. But I would love to see that because it gives us so much more biological information. In terms of leaflet modification, using electrosurgery like electrified wire, mechanical, or a combination are the current options out there. I'm sure someone's looking at a laser-based approach, but certainly all the dedicated devices for that right now are using one or either mechanical or laceration using electrosurgery.
Yeah, the third question was on LP little a, you know, phospholipid.
Yeah, something we have taken a brief look at in transcatheter valves. I think this may differ slightly between transcatheter and surgical, but in terms of the native valve, we've spent a lot of time looking at that and should have a paper coming out soon that we just submitted the revisions for, in which we looked at not just the native valve, but the whole neosinus, the native neosinus, and looked at what the features of that are, and really think it's more related to stasis and inflammation and less lipid driven.
Well, I also have several questions, but I'm
Okay.
going to hold off because we're at past time. But I think the questions really show the interest. Very exciting talk, Stephanie. Thank you very much for coming. And we look forward to spending some time with you today. Thank you, everyone, and have a great day.